Adil, I'm here to start this session. I think it's about time that we should. I would like to introduce our panelists for this discussion today. Dr. Shahzad Anwar, he's CEO of Ifat Anwar Medical Complex, Lahore. He's Director of Pain and School of Pain and Regenerative Medicine, University of Lahore. He is MSc Pain Medicine from UK. He's a Diplomat Pain Medicine, Harvard University, and Fellowship in Interventional Pain Medicine from Hungary. He's Diplomat American Board of Regenerative Medicine from USA and Fellowship in American Academy of Regenerative Medicine from USA. He's will be presenting along with Dr. Zaigam Abbas. He is currently working as an associate professor in Department of Microbiology and Molecular Genetics, Punjab University, and he is a Diplomat American Board of Regenerative Medicine and PhD in Immunology University from Nottingham, England. The third participant is Dr. Irfan Karamat. He is a Senior Registrar, Jinnah Hospital, Lahore, CEO of Ibrahim Eye Hospital, Lahore. He's a Diplomat American Board of Regenerative Medicine, and he's done his fellowship in Vitreoretina from Turkey and a fellowship on Vitreoretina from King Edward Medical College, Lahore. First of all, to start the session, I would like to invite Dr. Zaigam Abbas to start the presentation. Thank you very much.
Bismillahirrahmanirrahim. Thank you very much, Dr. Adil, for the generous introduction. Just to highlight the potential of regenerative medicine, the global market of the regenerative medicine in 2023 was $16 billion with a profound growth rate of 25 to 30%, and it is expected in 2026 the global market of the regenerative medicine will reach up to 40 to 60 billion $, which is almost equal to the total budget of Pakistan, and which highlights the significance or the potential of the regenerative medicine in coming days. In order to practice regenerative medicine, the minimum requirement is to establish a well-equipped and well-standardized cell processing lab is the basic need to practice the regenerative medicine lab. And today I will talk about how to establish and the optimization of the standards of the protocols to establish a regenerative medicine lab and regenerative biologics. In order to establish a successful regenerative medicine lab, we need two equally important component. One component is the administrative one, and the second component is the facility of the lab or the infrastructure of the lab. These both components are very important. Just few things about the administrative components. Number one, and then most important, is the development and implementation of the SOPs to work in the regenerative medicine lab. Starting from cleaning of the lab to do all the protocols, to do all the things which we are doing in the regenerative medicine lab, all the SOPs should be developed in hand. And second one is the local approval of the local approving authorities, which in our case is Punjab Healthcare Commission. Punjab Healthcare Commission approves the regenerative medicine lab. And the third one is establishing reporting process and the documentation. And if we talk about the facility or the infrastructure of the regenerative medicine lab, the most important thing in the infrastructure is the design of the regenerative medicine lab and the equipment, and also the personnel who works in the regenerative medicine. They should be skillful. And yeah. As far as the regulations governing clinical applications of adipose-derived stem cells, the regulations are the quality assurance systems to develop regenerative biologics. According to the FDA defines human cells, tissues, cellular and tissue-based products into two categories. One is the minimal manipulated, and the second one is the more than minimal manipulated. For the category A, minimal manipulated stem cells, FDA CGTP, FDA CGTP means GTP means CGTP and FDA CGMP. These are the quality assurance systems of the FDA. FDA CGMP practices, good manufacturing practices include a good facility and the manufacturing process so that the products can be and the raw material can be traced. And the process, it includes the process and the SOPs as I mentioned earlier, and the packaging, raw material testing, and the tracing include in the FDA CGMP facility. And if we talk about the FDA CGTP, good tissue practices of the FDA, it focuses, in order to, I should mention it, in order to work the regenerative medicine lab, we at least need a CGTP, FDA CGTP facility. So according to the FDA CGTP, we need FDA CGTP, it focuses particularly on preventing cellular or the acellular biologics to prevent contamination with the infectious agents. In order to prevent or in order to avoid the contamination, we need basically a clean room or a good regenerative medicine lab to ensure safety, quality, and identity of these cellular products. So if we talk about the facility and the clean room design, so basically we need clean room to work with the regenerative medicine lab. Clean room covers all the requirement of CGTP facility. In ISO 146441, clean room is defined as a room in which the concentration of the airborne particle is controlled and which is constructed and used in a manner to minimize the introduction, generation, and retention of particles inside the room, and in which other relevant parameters such as the temperature, humidity, and pressure are controlled as necessary. And in order to achieve these parameters in the clean room, we normally install HVAC system. HVAC system linked with the backup generator ensures HEPA filter air supply in the clean room, controls temperature and humidity in the clean room of the regenerative medicine lab. This is about the design of the regenerative medicine lab and the requirements of the different parts of the clean room. If you look here, this is the lab at the Ifat Anwar, this is the map of the regenerative medicine lab at Ifat Anwar Medical Complex. Here is the entry of the regenerative medicine lab, and right after the entry, here's the degowning area, then here is the preparation room, and from here we enter into the clean room. And in order to enter the clean room, we have 3 buffer zones. First, this is the first buffer zone, second buffer zone, and the third buffer zone. And from third buffer zone, we enter into the clean room where we process all the regenerative processes. Okay, so this is the clean room. I will also show the real-time lab at the end. So, so according to the ISO standards, the clean room must be according to the ISO 7, and in the clean room, the particle number should not exceed 3,52,000. And in the buffer zones, it should meet ISO 158 criteria, and the degowning area should meet ISO 9 standard. And the HVAC system, which maintains the temperature and humidity of the clean room, along with air filtration through the HEPA filter under positive pressure. This is an example of the clean room. If you look at the clean room, this is the model clean room facility. This is an example of the clean room facility. So if you see, all the walls and the floor of the clean room was epoxy painted. It is required because we need non-porous, impermeable surfaces in the clean room. Normally we use epoxy paint, or the marble is also fine in the clean room. And in the clean room, the bench tops are recommended. Stainless steel bench top are recommended to work with. And of course, there are more equipments which I will talk in later in this talk. There are many instruments which are essential to work in the regenerative medicine lab. This is the personal protective equipment example which is required to work in the regenerative medicine lab. It includes the hood, cap, face mask, gloves, coveralls, and the boots. And in our experience, the autoclaved garments are best to work in the regenerative medicine lab. We use autoclaved garments. So in order to sanitize and sterilize the lab, we normally use 70% ethanol for benchtop cleaning, the reagent bottles, and the biological safety cabinets. And along with 70% ethanol, we also use 10% bleach and 5% Dettol to sterilize the surfaces of our regenerative medicine lab. In order to fumigate, we use formalin, and we normally fumigate our lab weekly. And UV is also used to sterilize the lab settings, and autoclave is used to sterilize our lab reagents. So this is the lab cleanliness and sanitization is recorded in the cleaning log, which is displayed in the lab. Now coming to the quality control of the lab, regenerative medicine lab, and the quality control of the regenerative biologics. The first quality assurance is the index of microbial air contamination, because the basic thing which is required in the clean room is to control the bacteria in the lab. So we normally check the presence of bacteria by using index of microbial air contamination. There are different methods to check the microbial air contamination. We normally use air settling method, in which we use Petri plate. We place the Petri plate in the lab for 1 hour, and we use 1/1/1 formula, in which we place the Petri plate 1 meter above the floor and 1 meter away from all sides. And then we place the plates in the incubator, and next day we count the number of colonies, and we compare the number of colonies with, this is the recommended limits for the microbial contamination according to the European Union good manufacturing practices, and 0 to 1 colonies. If the 0 to 5 colonies comes in the plate, it is it shows a very good lab. And the number of colonies, if they come from 6 to 25, it is good. And I should mention here, in the clean room, the number of colonies should not exceed 5. Number of colonies should always come under 5. And in the biological safety cabinets, no bacterial colony should come. This is about the production of regenerative biologics, their methods. In our lab, we are producing many regenerative biologics, and amongst them, one is the PRP. We are producing PRP by using T. Harrison method. We are producing adipose-derived stem cell, conditioned media, secretome, and the exosomes. We are producing umbilical cord-derived stem cells, secretome, and also the exosomes, amniotic fluid, and in routine we are doing SVF preparation for the clinical applications. And this is the flow chart which is showing how we produce it. Amniotic fluid, we simply centrifuge the fluid. We remove the components, the solid components in the fluid, and then we filter this amniotic fluid with the 0.4 micron, again centrifuge it, and then we again filter this with the 0.2 micron filter to avoid any contamination with the bacteria. And in order to derive the umbilical derived stem cell conditioned media or the stem cells, we derive the stem cells from the umbilical cord. We culture them, and then we collect the supernatant, and from the supernatant, exosomes are collected. So I think my time is over. I will just wind up in a minute or so. This is about the quality assurance of the adipose-derived stem cells and the umbilical cord-derived stem cells. In order to assure the quality of the stem cells, whether they are derived from the adipose or from the umbilical cord, they should have three properties. Number one, they should attach with the plastic membrane. Number two, they should positive for these parameters. And number three, they should maintain the plasticity. So this is the example. This is our lab cells, adipose-derived stem cells produced in our lab, and this is the picture of the umbilical cord-derived stem cell in our lab. Quality control of the exosome, and with this I will end my talk. This is the quality control, what we test for the exosomes. For the exosome, for the secretome, the total secretome, we do ELISA. In order to check which growth factors are present in it, we just check three growth factors, EGF, VGF, and PDGF. We check their presence in the secretome by using ELISA. And second one we use Western blot to check the markers of the exosomes, whether they are present in our exosome preparation or not. We check the CD9 and CD65 markers. These are the markers of the exosome. They should present in the exosome. And the third one is the DLS analysis. We check the size of the exosome, because size of the exosome lies from it is up to 100 nanometer. So this is the total secretome, which is showing they contain both the exosomes, extracellular vesicles, and sometimes they also contain the apoptotic bodies, but the purified exosome, they only contain the exosomes here. We confirm this with the DLS. Thank you very much. There are more things to share, but my time is over. Thank you very much.
Now I would like to invite Dr. Shehzad. He would be delivering a very important topic and talk on regenerative medicine.
Bismillahirrahmanirrahim. Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you so very much, OSP, Dr. Irfan, for giving me the opportunity to share some basics and some of our research work we have done over the years with regenerative medicine in different specialties. So the title is Regenerative Medicine Unveiled. Right. Regenerative medicine unveiled a comprehensive overview of healing and restoration in modern healthcare. These are my disclosures. I'm CEO of Ifat Anwar Medical Complex, a 150-bed tertiary care hospital, Director School of Pain and Regenerative Medicine at University of Lahore. This is the first proper degree awarding institute in the world in regenerative medicine. I'm faculty and examiner for the World Institute of Pain, and there are no financial disclosure relevant to this talk, though I talk for different organizations internationally. So before coming to regeneration, I would be talking a bit about aging and degeneration, right? In one of the previous talks in the last session, there was a comment that aging is inevitable. There is no doubt aging is inevitable, but disease is not inevitable. We can gracefully age, we can age healthy, and we can die comfortably without having so many debilitating diseases. And regenerative medicine is one of the keys of the modern healthcare system to have graceful aging and all those things. So aging, also known as senescence, refers to the process of becoming older, which is characterized by a gradual decline in biological function and the body's ability to adapt to metabolic stress. So this is the key. With aging, what happens? There is more metabolic stress. There is more catabolic mechanisms going on in the body, degenerative diseases, osteoarthritis, all those things. So if we can slow down those conditions and we can even partially reverse them, that is the main aim. It encompasses a range of physiological changes that occur over time, including deterioration of cells, tissues, and organs, leading to an increased risk of disease, frailty, and death. So what happens in de-aging is that breakdown mechanisms, they overweigh the repair mechanisms. The basic principle of regenerative medicine is to shift that balance from degeneration or breakdown to the regeneration. National Institute of Health, USA defines regenerative medicine as an emerging field that focuses on repairing, replacing, or regenerating human cells, tissues, or organs to restore or establish normal function lost due to age, disease, damage, or congenital defects. This field holds the promise of regenerating damaged tissues and organs in the body by stimulating previously irreparable organs to heal themselves. So this regenerative medicine is really a hot topic world over. If we look at PubMed, there is dramatic rise in PubMed references in last few years. Only during the 2023, we can find more than 13,000 references on PubMed, including nearly 300 systemized analysis and meta-analysis, systematic reviews. So this is screenshot. If we search stem cell therapy, regenerative medicine, the figure comes about 113,000, right? And if we search stem cell therapy, the count is even higher. It's nearly 175,000. So lots of publications, lots of references. So coming to regenerative medicine, there are two basic branches. One is the cell-based therapies we physicians are concerned with, and the other is tissue engineering, bioinformatics, all those things which our basic scientist friends are working on. We have different options for regenerative treatment options. They include both acellular and cellular products. If we talk of acellular products, exosomes are very common these days, and other microvesicles. Then we have alpha-2 macroglobulin, both autologous and recombinant, high-density collagen, recombinant growth factors, intradiscal fibrin, all those things. These are all acellular. And regarding about regenerative medicine, we need to be clear. There are regulatory authorities like human organ transplant and all those authorities. They are applicable to tissue cells. And as per Pakistani law, if some cell or tissue is transplanted from one living or deceased person to the other, then it's transplant by definition. So the autologous therapies and acellular therapies, they don't fall into the category of transplantation. So HOTA or P-HOTA in Punjab, it does not fall into their legislation. The only regulatory authority we need to deal with is Pakistan Medical Dental Council for the accreditation of the qualifications, and for healthcare establishment facilities is the Punjab Healthcare Commission, or in Islamabad, similar authorities. For cellular therapies, we are doing the platelet-rich plasma, autologous stem cells, again BMAC derived, adipose derived stromal vascular fraction, and most modern is peripheral blood derived very small embryonic like stem cells. Allogenic, especially umbilical cord derived, but again in the form of acellular. When we derive exosomes from them, then they can be used. Otherwise, they are still in the experimental stage. Then laboratory expanded cells, again from the same patient to the same patient is the donor, patient is the recipient. Then we can combine all these platelet plasma treatment with stem cells and exosomes. So may I ask how many people here in the audience are doing PRPs? So, I mean, in other specialties, especially aesthetics, derma, orthopedics, spine, pain, lots of regenerative PRPs are being done. But the problem is seeing somebody doing PRP, getting a centrifuge and doing PRP and just taking out the, and injecting it without knowing what its composition is, it can be more dangerous. So I would be focusing on PRP, at least this one thing we can take home, okay, where to put what type of PRP. PRP is basically platelet-rich plasma, which has been enriched with PRP, which has more than baseline, right? As a concentrated source of autologous platelets, PRP contains and releases through degranulation several different growth factors and other cytokines that stimulate healing of bone and soft tissues. This is how it looks like. We take the sample from the patient, centrifuge it, and then we get three parts. The lowermost part is the RBCs, it is about 45%, then the centered grayish, dirty looking part is the buffy coat. This contains lots of blood fluid, WBCs and platelets, and then the upper 55% is the platelet poor plasma. It's very important to know that at least two basic types. One is leukocyte-rich PRP, and the other is leukocyte-poor PRP. Leukocyte-rich PRP is the one which we get from the lowest part above the RBCs. So this gray buffy coat plus this part. This contains lots of growth factors, but it also contains lots of WBCs. The problem with this, it contains lots of also some degeneration causing interleukins and others as well. So when we inject leukocyte-rich PRP in any joint or intradiscal or intraocular, it may cause degeneration rather than regeneration. So this type of PRP should never be injected in any closed surface. For our eye consultants, I mean, it should never be injected subtenon or whatever routes you use. So, and for our specialty, we never inject in intradiscal or intraarticular. For that, the best composition is leukocyte-poor PRP. Leukocyte-poor PRP contains less number of platelets, very few WBCs, no RBCs, but it contains lots of structural proteins, especially alpha-2 macroglobulin. Alpha-2 macroglobulin is one of the most potent protease inhibitor. And in all the joints and disc and all the connective tissue, the reason for age-related degeneration is increased concentration of proteases. As their concentration increases, the cartilage, all the synovial things, it gets starting destroyed. So we need to have protease inhibitors, and that is contained in the leukocyte poor part. Same is for the intraocular injections. And Dr. Irfan will talk about that. There are lots of growth factors in PRP, starting from ILGF1, SDF1, bone morphogenic protein, then GDF, all those things. So it's a very, very strong source of stimulation, regeneration. And in addition to this, when we inject PRP, it attracts through chemotaxin and cytotaxis the inherent stem cells, especially the mesenchymal stem cells, which are the workhorse for regeneration. The count of PRP is very important, right? So optimal count is between 1.5 to 3 million, but the inhibition comes at if the count is more than 5 million, but none of the point of care PRP system which is available, we can achieve this level. So we should be worried. So no concentration less than 500 or equivalent is just giving a platelet poor plasma. So ideal concentration should be about 3-fold or to 5-folds. And then again, a beautiful study done that Leukocyte-rich PRP destroys the cartilage and damages, and then it should be RBC-free, leukocyte-poor PRP for any closed organ or any intra-articular or intradiscal injections, right? So the other next step, or the second generation of regenerative medicine, is stem cell treatment. Stem cells are primitive, undifferentiated cells with the ability to divide for indefinite periods, to give new stem cells, or to differentiate, giving rise to specialized cells. Stem cells have three main characteristics. Number one is they are unspecialized, undifferentiated cells. They can divide and renew themselves sometimes after long periods of time in response to injury or insult or any ischemia or anything. Under certain physiological or experimental conditions, they can give rise to specialized cells. This is how a stem cell divides. It goes through two types of mitosis: typical mitosis, giving rise to two daughter cells, and atypical mitosis, where it produces a daughter cell and a free lipid which combines with a progenitor cell to produce a specialized cell. Right, different types: embryonic, induced pluripotent, umbilical cord derived adult stem cells. We are concerned with these autologous ones. Bone marrow aspirate derived stem cells, then adipose derived stromal vascular fraction, and peripheral blood derived very small embryonic like stem cells. They have these four characteristics which are the base of all the therapies we are doing: self-renewal and potency, lineage, multi-drug resistance, plasticity, transdifferentiation. So the bone marrow concentrate, or the bone marrow derived stem cells, they contain 90% to 95% hematopoietic stem cells. 1 in 15,000, 5% or so are mesenchymal stem cells, 1 in 250,000. They also contain adult precursors of B and C cells, WBCs, concentrated platelets, and all the growth factors, scaffolding proteins, especially fibrinogen and fibrinactin, alpha-2 macroglobulin, anti-inflammatory cytokines, IL-1 beta and 6, 8, BMP2 or 7. Hematopoietic stem cell give rise to all the types of blood cells. The important role in regeneration is they can differentiate, because MSCs, which are 5 to 10%, they, by producing cytokines and all those things, they stimulate the replication and their anti-inflammatory effect, and also the immune modulating effect. Then the adipose-derived stem cells, patients' adipose is taken about 20 to 25 ml, or maximum up to 100 to 150 ml, then incubated, treated with antibiotics, emulsified with collagenase 1. Then that small part, that pallet, that contains a beautiful concentration that is called stromal vascular fraction. It contains mesenchymal progenitors, pre-adipocytes, endothelial cells, pericytes, T cells, M2 macrophages. So beautiful combination. Then the most modern and most effective treatment is peripheral blood-derived, very small embryonic-like stem cells. There is a very small population which is CD133 positive, and it's of non-hematopoietic region coming from the bone marrow. After tissue injury, including acute MI or other diseases, these bone marrow derived VSCL are mobilized into the peripheral blood, and they home to the damaged tissue and cause the healing, start the healing process. This is mechanism. This primordial germ cells, they give rise to VSCL, and then they, through an intermediate hemangioblast, give rise to hematopoietic stem cells and epithelial, then mesenchymal stem cells and tissue-specific stem cells. How this procedure is done: normally the concentration is too low and we can't harvest them from the peripheral blood. For that, what we do is we inject patient with filgrastim, that is a granulocyte colony stimulating factor. This is given subcutaneously for 4 consecutive days. Patient report on the 4th day, and at that time the concentration from 1 to 1.5% to reach about 26 to 30%. From at that time we can harvest it. it's the most easiest procedures to be done. Even with lipo and BMAC, it can cause pain. With lipo, we know what hazards can be. This is the system we are using, and it's most commonly used world over. Different kits are being used. Patient is talking, and simply you have to take an IV line in with 16 gauge cannula, the same with the blood. Then the Latham bowl, it processes it, and this is where the white cell and the mononuclear cells, they come. Right? Exosomes. Exosomes, again, the third generation of regenerative medicine at this time. They are tiny single membrane organelles ranging in size from 30 to 150 nanometers. They are released in high quantities from rapidly dividing cells, especially stem cells, T and B cells, and even by the cancer cells. They contain each and everything, all the qualities and proteins from the parent cell. Exosomes, they are being used in different treatments: regenerative medicine, anti-aging, aesthetics, drug delivery, immunotherapy, biomarker for disease diagnosis, and gene therapy. Some of the pictures we have done in my own specialty of spine, and also from other, we'll be sharing some pictures which Irfan and his team has worked. This is a non-healing fracture of C7 spinous process. Patient presented to us 9 months after this non-healing fracture. We injected locally, also the systemic, and you can see on scan, this is previous, this is after the local and systemic complete healing of the, and this was 4 months after giving the regenerative medicine treatment. Another patient with huge bulge, impeding cauda equina, refused to undergo surgery. We performed plasma coblation nucleoplasty and then intradiscal cells, and then you can see not only this disappeared, but also the hydration and the disc health also improved. For degenerative osteoarthritis, you can see the difference. No cartilage here, beautiful cartilage developed 6 months after the injections. Another, this is 3-year follow-up. You can see the difference, both all the healing, not only of the cartilage, but also healing of the bone. You can see the destruction of the bone as well. Right? This is a young patient, a young dentist with rheumatoid arthritis. You just see how the hip is destroyed. We treated her with intraarticular PRP for 2 sessions, followed by peripheral blood-derived stem cells, and this is her joint after 6 months of treatment. Almost came back to normal. Another osteoarthritic hip, you can see in 12 months time. Another case. So this is how we do it. For other diseases, especially in kids with neurodevelopmental conditions, CP, lots of benefits, spasticity, left-sided hemiplegia. In 6 months' time, lots of. So we have published our work internationally. So this is relevant to your specialty, and Dr. Irfan and our team has worked on this combined. This is one patient of non-healing trophic ulcer. You can see pre-treatment, post-treatment, along with all the symptoms, burning, redness, and from her vision came back from vision counting to 6/12. 6/12, right? I'm not familiar with all the, right? So another patient of Steven Johnson syndrome, only given the eye drops, in Tears Natural, we added the secretome and the amniotic fluid, different concentration developed by Dr. Zegam, and you can see the improvement in 6 weeks' time and all those things. So perhaps the first reported case of retinoschisis, I'm not familiar with the disease, but you can, मेरे से बहुत बेहतर आप appreciate कर सकते हैं कि how the things has improved after the 3rd session just in 9 weeks. So there are also other indications the way forward is we need to learn from others, need to learn from our own mistakes, our experiences, integrate and collaborated efforts are required to develop safe and effective practices, products. As a Muslim, as a human being, I firmly believe that there is no disease for which Allah Almighty has not provided the cure. We simply have to discover it. Thank you so very much.
Thank you very much, Dr. Shehzad. Next, I would like to invite Dr. Irfan Karamat to give his presentation. Thank you.
Bismillah ar-Rahman ar-Rahim. I'm Dr. Irfan Karamat, and thank you for attending this session. So far, what we have tried to establish that how a stem cell lab can be developed in a certain health facility, and what are the modalities like stem cells, PRP, exosomes, sclerotomes, which are and how do they work, how do we get them separated. Now my part of discussion is that how can we inject them in or how can we use it in our ophthalmological applications. There are, so far what we have gone through the different research data, that there are 5 different routes through which we can administer regenerative modalities in ophthalmology. Those are intravitreal, subretinal, suprachoroidal, subtenon, and topical. Now, talking about intravitreal route, it is one of the effective route, but we can deliver an inadequate dose for regenerative modalities or regenerative biologics to work. They need a certain percentage of cells. For example, if I talk about ophthalmology, what we conclude that, or what we believe that at least 1.52 million platelets, exosomes, or stem cells should be present in 1.52 ml of fluid, which we inject in certain area. But through intravitreal route, what we can inject is that almost 0.1 ml of the fluid, which is inadequate, and it doesn't have that much of exosomes or stem cells. And apart from this, it has tremendous, there are lots of complications which are attached to it. And those complications are subretinal fibrosis, intravitreal fibrosis, sublenticular fibrosis, retinal detachment, phthisis of the eye. So all these complications make intravitreal route not a favorite one. There are certain studies which led to this conclusion. One, I just mentioned that out of 30 patients, 3 ended up into retinal detachment. There was another study which got abandoned because of, in that study, 10 patients were included, and out of those 10 patients, 5 had retinal detachment and phthisis. So they abandoned that study. Second route, that is subretinal. Again, there is a high, there's a quite a long learning curve for this. What we do that we use 40 or 42 or 40 or gauge cannula. We go intravitreal and we inject the regenerative modality. What it can do that it can damage Bruch's membrane. It can create an enlarged retinotomy or reflux of the regenerative biologics into the vitreous cavity, again giving rise to extensive uncontrolled fibrosis, membrane formation, retinal detachment, subretinal fibrosis, and again into a phthisis. Both these routes are not that favorite because of their higher complication rates. Now the next one is suprachoroidal route. Suprachoroidal route is one of the most effective. There are no complications attached, almost no complications attached to it. And there are 2 techniques, Lamellais technique and modified Lamellais technique. What is that? We create a 5x5 scleral window in a supratemporal quadrant, which you can see here, that what we do in TRAB, that almost 12 millimeter from the limbus, we create a 5x5 window in sclera. We raise this flap and we put or implant any regenerative modality, that is exosomes, that is stem cells, that can be PRP, which is impregnated with patient's own fat, which is taken from the same orbit, And we again close this window which we have created in supratemporal quadrant. This is Lamellie's technique. Again, it has a very long learning curve. During this surgery, you can perforate the eye, and you can end up in a grave complication. But it is quite effective as well. There's another technique which is known as modified Lamellie's technique. In that technique, after creating this scleral window, we raise another short, or we polish, or we take another small surface which is of the sclera, which is underlying that window, and so that we get more closer to the choroid, and then we impregnate, or we put that regenerative modality, and we close the scleral window. Now, talking about the subtenon route, how does it work? If you look at this slide, there are certain receptors which are tyrosine kinase receptors. This data got published in 2011. Jarosky showed that there are 4 receptors in the perilimbar region, in extraocular muscle insertion, at the uveoscleral tract, and around optic nerve. At these 4 places, there are first certain tyrosine kinase receptors. Through these tyrosine kinase receptors, autologous PRP or stem cell modalities like exosomes or stem cells itself, they get absorbed or attached. If we talk about direct diffusion, if any treatment modality or biologic have a size of less than 75 kDa, that is kilodalton, that peptide can pass directly through sclera. One of its example is that we give subtenon steroids, and we find them effective in different clinical applications. If it's more than 75 kDa, it needs another transportation method which is known as electromagnetic iontophoresis. What is that? It's a long discussion, but certain charge is given to the injected particle, and because of that ionic positive negative charges, that particle gets absorbed through the sclera if its size is more than 75 kDa. And having said that, certain peptides which are present in, or exosomes which are present in PRP, growth factors, or stem cells, they have size varying from 60 kilodalton to 110 kilodalton. So if we do not use electromagnetic iontophoresis, which is being used in America, in Turkey, and this method has got its FDA approval as well, even we do not use this, even then there are certain peptides which get absorbed directly through the sclera and through these receptors which are present at 4 different parts of the eye. This article got published in 2020, showing that management of retinitis pigmentosa through platelet-rich plasma or combination with electromagnetic stimulation, that is iontophoresis, which I just mentioned. And it showed improvement in visual acuity, best-corrected visual acuity, visual field, and multifocal ERG. This article showed a comparison of suprachoroidal and subtenon stem cell delivery methods in patients with retinitis pigmentosa. This article again showed that the results in best-corrected visual acuity, visual field, and multifocal ERG were comparable. Conclusion shows that this study demonstrated beneficial effect of suprachoroidal and subtenon administration of umbilical cord-derived mesenchymal stem cells on best-corrected visual acuity, visual field, and multifocal ERG. Another data which showing that improvement in visual acuity in patients of retinitis pigmentosa through PRP injected subtenon space, through subtenon space. Now, I just talked about suprachoroidal, subtenon, intraorbital, and subretinal. The 5th approach which we are working on these days is topical. What we have developed is a product or a biologic which is extracted exosomes from umbilical cord and adipose tissues. Because exosomes are acellular product, So it does not have any jurisdiction which comes under HOTA, and through it's lawful to be used from one human being to another human being. So what we established or developed, that we took those exosomes and we mixed it with certain preservative so that its shelf life is almost 3 to 4 weeks. And in topical form, if we given 4 times a day for 3 to 4 weeks, it has excellent and miraculous effects on patients like non-healing ulcers, Stevens-Johnson syndrome, and severe dry eyes. So there are 5 different routes which I just mentioned, and out of those 5, 2 are effective, have good results, and having almost 0 side effects or complications. Thank you.
Thank you very much, Dr. Irfan. A very nice presentation. Next, I would like to invite Dr. Salman Nasir, who would be presenting on regenerative therapy in retinal disorders.
Assalamu alaikum. I am Dr. Salman Nasir, resident ophthalmology at Jinnah Hospital, Lahore. I will be discussing the role of regenerative medicine in retinal dystrophies. So the retinal dystrophies are a group of degenerative disorders of the retina with clinical and genetic heterogeneity. Mostly they affect the RPE photoreceptor complex and the choriocapillaries. To date, more than 270 genes have been identified to cause retinal dystrophies. They could be rod-dominated, cone-dominated, or mixed type. Overall, the most common retinal dystrophy is retinitis pigmentosa, and the most common macular dystrophy is the Stargardt disease. We did a prospective interventional case series on 200 patients with confirmed diagnosis of RP through ophthalmological testing. Out of these 200 patients, the age range was between 18 to 50 years and included both genders. The vision was between 618 to counting fingers, having various degree of visual field loss. Comorbs such as diabetes, glaucoma, and cataract were ruled out. So how can we apply the regenerative therapy in retinal disorders? The regenerative modality could be embryonic stem cells, the adult stem cells, and exosomes, also called the growth factors. Sources could be embryonic or adult sources. The notable embryonic sources are the blastocysts, which are the true source of stem cells, the umbilical cord, cord blood, exosomes from the umbilical cord. The adult source could be from the adipose tissue, the bone marrow, peripheral blood, and the growth factors from peripheral blood. There were 3 primary outcomes of our study. These included the visual acuity, macular thickness on OCT, and the visual fields, limited mainly because of the financial burden on the patients. So what do we note? We noted that the visual acuity in the patient improved on an average 2 steps in those patients in whom the visual acuity could be recorded on the Snellen's chart. In those patients with very low vision, we also noted that the patient's visual acuity improved from hand movement to counting finger, and from counting finger at 1 feet or 2 feet to counting finger at 4 or 6 feet. The macular thickness also improved, and average decrease in the macular thickness was about 40 to 50 microns. There was also subjective improvement in visual fields, color vision, and contrast sensitivity as well. So these are the pictures from the patients. In the picture 1, you can see the improvement in the macular edema. Also, the cystic spaces are regressed before and after treatment with the injection. Similarly, on the right side, in the second patient, there is significant improvement and the regression of cystic spaces pre and post treatment. These are the macular maps of some of the patients which show pre and post treatment pictures. There is an overall improvement in the macular thickness before and after the treatment, as you can see. Regarding the visual fields, there was almost some degree of improvement in the mid-periphery after the treatment. So regarding the safety profile, as Dr. Irfan already had discussed, Different routes can be approached for the application of regenerative therapy. It could be intravitreal and subretinal. Those are associated with high degree of complications. Suprachoroidal, subtenon, and topical. Among these, the subtenon and suprachoroidal are the safest strategies. Studies show that intravitreal route has been associated with numerous complications, notable being the retinal detachment and vision loss. Also, studies have established the efficacy and safety of subtenon route as an effective way of administering regenerative modality for retinal dystrophies and other conditions. So what we concluded is that regenerative therapy is a novel treatment in the treatment of retinal dystrophies. Earlier studies have shown promising results in improving both the visual fields and visual acuity. Even improvement of a single line in the visual acuity of a patient can make him become a meaningful and productive member of the society. Similarly, studies have also developed the effectiveness of subtenon and the suprachoroidal route for the administration of stem cells. Regarding the safety profile, subtenon is beneficial in the way that it can act as a depot preparation which result in a sustained release of the stem cell therapy to retina. Thank you.
Thank you very much, Dr. Salman. Our last presentation for today is role of regenerative medicine in non-healing corneal ulcers by Dr. Muhammad Ahmed. Arjun, please.
Bismillahir Rahmanir Rahim. I am Dr. Muhammad Ahmed, resident ophthalmology in Jinnah Hospital, Lahore. Today I will be discussing the effectiveness of these stem cells in the non-healing corneal ulcers. Corneal ulcer is a corneal epithelium defect with underlying stroma. It is a potentially vision-threatening ocular emergency. And the complication due to corneal ulcers can be corneal scarring or perforation, glaucoma, cataracts. In United States, annually 30,000 to 75,000 people presents with the corneal ulcer, and 12.2% of these patients undergo corneal transplantations. Now, coming toward the causes of the non-healing corneal ulcers, that can be persistence of infection, treatment toxicity, steroid use, neurotropic keratopathy, diabetes mellitus, dry eyes, exposure keratopathy, and the chronic conjunctival inflammation. These patients experience following symptoms like reduced corneal sensitivity, corneal erosions, decreased tear production, photophobia, and blurry vision. The available treatment for the non-healing corneal ulcers at the moment are the amniotic membrane grafting, etanercept, which is the tissue necrotic factor inhibitor, and the immunosuppressants such as cyclosporine. However, their effectiveness in long-standing cases is limited due to the absence of growth factors that promote the wound healing. Now here comes the role of the stem cells, in which we use the stem cells for these non-healing corneal ulcers. Stem cells have the capacity to regenerate the damaged tissue and reinstate the visual function. Upon the corneal injury, the endogenous mesenchymal stem cells are triggered and they are mobilized to the site of injury by the peripheral blood. And they act through, when we give these exosomes, they act through by direct cell replacement, and they help wound repair by reducing the inflammation, promoting the wound healing by angiogenesis, and limiting the immune response. Now, there are the many studies which shows that the amniotic fluid is helpful in treating the dry eyes, but there is no current effective treatment for the long-standing ulcers. However, trials using a combination of artificial tear eye drops with amniotic fluid and stem cell conditioned media that contains growth factors and exosomes have shown the promising results. This slide shows how we get these stem cells, exosomes, by amniotic fluid, umbilical cord, or adipose tissue. Now coming toward the stem cells therapy for long-standing non-healing corneal ulcers. We included 7 patients in our study which have non-healing corneal ulcers and have burning sensation, photophobia, and positive fluorescein stain. We gave them our exosome drops 4 times a day for 1 month, and after 1 month, their agonizing symptoms was reduced, and fluorescein stain was also negative. This is the case. This is the 60-year-old female, and have long-standing corneal ulcer which was non-healing, and she was having this ulcer for the last 10 years and have multi-center treatment for this ulcer. We gave her these exosomes for 2 months, and after 2 months, her pain, photophobia, and blurriness was improved, and fluorescein stain was also negative after 2 months. This is another case of the 50-year-old woman. She was diagnosed as the patient of the herpetic keratitis and was taking oral and topical antiviral for the last 3 years. At the time of presentation to us, she had counting finger vision at 1 meter distance, and she was having severe photophobia and blurring of vision. We advised exosomes 4 times daily, and after along with the topical antiviral therapy. After 1 month, she was totally pain-free, and her visual acuity was improved to 636, and at that moment we stopped the antiviral medication. And after 3 months of the exosome therapy, her visual acuity was improved to 624 and did not encounter any recurrence of the symptoms which was previously she was having treatment of the ulcer, and after some time there was recurrence of her symptoms. And this is the case of the Stevens-Johnson syndrome. This lady had bilateral corneal epithelial defect and severe photophobia and watering. And just after 4 days of her treatment, the corneal luster was back, and her agonizing symptoms was also reduced to normal. Thank you.
I'm sorry, I previously said that this was the last presentation, but we have another presentation on regenerative medicine in ophthalmology from Dr. Syed Salman Gilani Sahab. Ajay, please.
Bismillahirrahmanirrahim. My respected ophthalmology faculty members. I'm an internist by profession, and this is my first outing at the ophthalmology conference. As I said, I'm an internist. I'm board certified in internal medicine, and I'm board certified in regenerative medicine as well. And I am looking after the regenerative medicine department at IRM. That is the Institute of Regenerative Medicine in Islamabad, which was founded in 2017. In the interest of time, and I was told that we're short of time, so I will try and go through these slides as quickly as possible, just to stay relevant to ophthalmology, because the presenters before me have already talked about what stem cells are, what are the different routes. I'll try and give you a sort of a overview of the research in ophthalmology these days. These are the pictures from our lab in Islamabad. just to give you an idea that generally the treatments available to us are either we have certain medications, drugs, or we resort to surgery. But with the advent of regenerative medicine, now there's a paradigm shift, and we have the power of our own cells to treat and heal a lot of conditions in all areas of medicine and ophthalmology as well. So regenerative medicine, this is a definition that has already been gone over with. When we think about regenerative medicine, the first thing that comes to our mind is stem cells, and that is true to an extent that stem cells are at the hallmark of regenerative medicine, but that's not the only way we treat patients with regenerative medicine. There is gene therapy, there's immunotherapy, peptides, ozone therapy, hyperbaric oxygen, nutrition therapy, 3D bioprinting, integrative medicine, functional medicine, photobiomodulation. There are so many that are available through regenerative medicine. Let me skip over a lot of these basic definitions because presenters before me have already gone over these by the definition, their characteristics. So these are, by classification, there are 3 different types of stem cells: embryonic, adult, and the latest technology from Japan is induced pluripotent stem cells. World over, the only types of stem cells that are in clinical practice are adult stem cells, but since Japan has allowed its use in clinical practice as well, so they are using induced pluripotent stem cells as well. Just to give you an idea, from the fertilized egg, this is just the stroll down your memory lane from your embryology. From the day 1 to 3 are totipotent stem cells that can make a complete human being, placenta and embryo. Whereas from day 4 to day 15, which is the blastocyst stage, those are pluripotent stem cells that can now only make the embryo and all of the cells from their embryo. And then multipotent stem cells, after that, when they have committed to a lineage, be it ectoderm, mesoderm, endoderm, now they are limited in their potential to what they can differentiate into. And here are a few examples from multipotent stem cells to fully mature cells. I'm going to skip over a lot of these. So the sources from where we can get the stem cells or these cells or tissues are embryo, umbilical cord, placenta, amniotic fluid, and most adult tissue. Umbilical cord stem cells, one of the presenters before put it in the embryonic category. It is not true. These are stem cells, adult stem cells from infant origin. So you cannot call them embryonic stem cells. It is also known as Watten's jelly. They're less invasive to harvest in bone marrow. They have a greater compatibility and they have banking potential as well. As far as adult stem cells are concerned, you can get the cells from almost all sorts of tissues. And this is the latest technology, induced pluripotent stem cells from Japan. As far as the clinical applications are concerned, this is a cartoon from Google, and you can see the outreach is far-reaching. You can treat almost theoretically any disease through cellular and gene therapy. As far as the applications are concerned, it has been used for tissue repair, autoimmune diseases, cancers, neurological diseases, blood disorders, and anti-aging. Again, these are the few examples of autoimmune diseases, cancers that have already been treated with stem cells. Heart failure, ocular surface diseases, other ocular diseases, cartilage repair, liver disease, hair loss, and anti-aging. And I just put this here. It was picked up by BBC. This is a Canadian designer who lives in Bahamas now, and he's getting stem cells injections every year, and he's claiming that he's getting younger every year through epigenetic testing. Now, I'll give you 3 quick examples of why do we need regenerative medicine or stem cells when we have the perfect solution of allopathy. Do you agree that allopathy is perfect? Do you all agree? I don't think so, right? So that's why we need alternative treatments, and that's why we have a lot of these modalities. So quickly, thalassemia is a huge issue in Pakistan. The treatments available to us are regular blood transfusion, folic acid supplementation, iron chelation. This is generally the treatment. But through HLA match, allogeneic hematopoietic stem cell transplant, or cord blood transplant, we can actually cure these children of thalassemia. And this is from last year in June 2022. This gentleman who was 45 years old, suffering with thalassemia, was cured of his disease through the use of gene therapy. This was the first in the history where thalassemia was treated with gene therapy, and it is on the horizon. It is FDA approved now as well. Osteoarthritis, the most common disease of the elderly, can be treated with the medication, and when all else fails, you resort to joint replacement. We know that joint replacement is not a perfect solution. A lot of times these patients are either unwilling or unfit for surgery. So we can use PRP and mesenchymal stem cells in osteoarthritis and other musculoskeletal diseases to treat this. And then hair loss, a huge issue. Okay, so I'll just quickly go over. Let me try and bring you to regenerative medicine and ophthalmology. Again, I had a few slides, but I'll just quickly go through. So the focus is retinal diseases, which could be retinal dystrophy, macular degeneration, retinitis pigmentosa, or corneal diseases. The challenges are that restoration of lost or diseased retinal epithelial cells and photoreceptors, suppression of inflammatory molecule, suppression of immune response, and inhibition of cell apoptosis. These are the studies. I only included level 2 and level 1 evidences here. In the interest of time, I can share these slides with the faculty, and then you can go over these. But I'll just give you the summary of it. The clinical trials were 1 to 2B. The number of patients were 1 to 200, and the types of diseases that were treated were retinitis pigmentosa, retinal dystrophy, and the number of stem cell progenitor cells were from 60,000 to 10 million cells. Then again, there is level 2 evidence for the use of progenitor cells for the in retinitis pigmentosa. These are all of the meta-analysis, all of the studies combined. These are the summary from that meta-analysis and the different types of stem cells that we use. So in summary, for retinal diseases, there is level 1 evidence stating that cell replacement therapy has great potential for vision restoration. In corneal disease, some of the presenters before me have already talked about this. These are some of the studies. As far as PRP is concerned, you can see there is very weak evidence of its use in ophthalmology. The best we could find was level 4 evidence. Now, as far as stem cells are concerned, different types of stem cells have been used. This is the outcomes of limbal stem cell transplant and meta-analysis. This is level 1 evidence in corneal disease, and I'm pretty sure a lot of you are using limbal stem cells in your practice in some form or another. Then the evidence for corneal disease, level 1 evidence suggests that limbal stem cell transplant can improve or stabilize the corneal surface disease with a low rate of severe ocular complications. Then gene therapy in regenerative medicine, I mentioned one of the application, the thalassemia, but this was the first VN drug that was approved, that is approved now by FDA and is used in retinal dystrophy. These are the results from that study. Then it has also been used, and this is level 2 evidence in age-related macular degeneration, and these are the conclusions from the study. I know everybody's saying that we are short of time, so thank you very much for bearing with me for this time. Thank you very much.
Thank you very much, Dr. Salman Gilani. Any questions from the audience if you would like to ask any of the presenters? Thank you very much. Now we would like to present the shields to the guest speakers and presenters. The first shield, sir, I would like to invite Professor Moeen, Professor Asad sir. Sir, please, shield ke liye aap aa jaएं. The first shield we would like to present to Dr. Shehzad Anwar to please come and get the shield from Professor Asad Aslam and Professor Moeen. Next, I would like to invite Dr. Zaigam Abbas to receive the shield. Dr. Munir. The next shield is for Dr. Mujib. Please come on the stage and receive your shield. And next, Dr. Sayyid Salman Gilani. Please come on the stage and get your shield. Thank you very much. Thank you very much. This concludes the session, and please, thank you very much for attending. Shukriya. Thank you.